Good afternoon, everybody. My name is Susan Pandya. I'm a medical director. I work at Agios Pharmaceuticals, and I'm overseeing the development of the IDH inhibitors in the solid tumor program, including cholangiocarcinoma. So the goal of my talk today is to give you a brief introduction. I think many of you are familiar with the IDH pathway in sort of the simplistic terms, and I know the subsequent speaker is going to go a little bit more in depth regarding the biology, so I'll wait for his talk to get into the nitty-gritty details. But I also want to focus on the clinical data that Agios has generated over the past year. So 2 years ago, one of my colleagues, Kate Yen, had come and spoken at the CCF and really delved deep into the biology of IDH and how we were applying our scientific understanding, specifically in acute myelogenous leukemia. We've now, over the course of the past year and a half, delved more into the solid tumor space. And so I'd like to show you some of the data we've been generating, and then ultimately, what are we doing in cholangiocarcinoma? So for those of you who are not familiar with Agios, we're based out of Cambridge, Massachusetts. Go Patriots. There have to be some Patriots fans in the room, okay? There are a lot of Bostonians here. We're very excited about Sunday. And so what we've been doing has been very involved in in cancer metabolism, but we have a pretty broad platform of development. And the goal is to really target dysregulated metabolism. So that can span not only oncology, but you can envision rare genetic diseases where we have an active program evaluating pyruvate kinase deficiency, and then ultimately really where every drug company is probably heading, and that's immuno-oncology, but we're viewing it more from the metabolic stance. And so we're very excited to be a part of that wave of very exciting, groundbreaking research, and hopefully we'll have drug candidates in the clinic in the coming years. So many of you have already heard of IDH. It's isocitrate dehydrogenase. So it's basically basically an enzyme that's involved in normal cellular metabolism. But when mutated, it confers neomorphic activity. And what that basically means is that the enzyme is no longer doing what it was meant to do. And what it's now doing is basically catalyzing the conversion of alpha-ketoglutarate to 2-hydroxyglutarate. And 2-hydroxyglutarate is felt to be an oncometabolite in that it basically dysregulates the DNA at the level of epigenetic and genetic level. And what that means, at least for the wider group of patients in the room, is that these cells are now rendered to be more in a primitive, non-differentiated state, so more cancer-like rather than differentiated and mature, obeying the normal signals that other cells do. So AG120 is a first-in-class oral potent reversible selective IDH1 inhibitor. So you may have heard of AG221 previously during previous talks, and that's an IDH2 inhibitor. So our focus today is on AG120, which is an IDH1 inhibitor. So at Agios, we've really had to think about all of these as rare diseases because they effectively are with respect to mutational frequency and also on their own, independent of mutations. We've really zeroed in on 3 areas for solid tumor development within our phase 1 studies, and that included intrahepatic cholangiocarcinoma, chondrosarcoma, and low-grade glioma. And I'll go into a little bit more details as we discuss the data in those patients that we've generated. And then, of course, our AML data set, which I have to say is the most robust data set that we have to date to really prove, or I should say demonstrate proof of concept with respect to differentiation. What's interesting is that 2-hydroxyglutarate, as I mentioned earlier, which is an oncometabolite, could be potentially a very useful biomarker in multiple diseases. And what I mean by that is that it can be measured not only at the level of the tissue, but also in circulation in patients who have solid tumors and AML, and also at the level of radiographic imaging through 2H-MRS or magnetic resonance spectroscopy. And that's more readily applicable to patients who have glioma. So you can envision in all of these scenarios, 2HD might be very important, not only to measure on target engagement, but in addition, mechanisms of resistance and or progression over time. So I'm going to apologize in advance. My fancy schema slide didn't really work the way I was hoping it would. But this just gives you a visual depiction of what it is that we're describing, and I can go into greater details when I show you the AML data that we have. So as a reference point, we've generated phase 1 data, and some of the speakers earlier this morning spoke to you about the cholangiocarcinoma data set that had been reported in late 2015. In the meantime, we've continued to enroll to this study. So while I don't have new data to show you in the cholangiocarcinoma patient population, I know that's not what you want to hear. I can reassure you in that we've enrolled several more patients, so we'll have a much more robust data set to speak to later on in the year, and I hope to have a chance to share that with the broader team and certainly the CCF community. I will focus your attention, though, on the other data that we've generated and how can we use some of the lessons that we've learned in these populations and apply it to our data set in cholangiocarcinoma patients. So let's start with AML. The story with AML has been evolving now for several years. And what's really been exciting is that we've been able to add to this data set over time, not only in a phase 1 study that's been ongoing, but also moving into first-line phase 3 trials in combination with chemotherapy regimens. So as you know, AML is a deadly disease. There's really the only curative therapy in this disease is bone marrow transplant. Oftentimes patients have to undergo several rounds of very cytotoxic, disabling chemotherapy that requires inpatient hospitalization. So oftentimes this is not considered an outpatient regimen the way most chemotherapy regimens are delivered in the solid tumor space. So this was a relatively refractory patient population that was evaluated. Okay, sorry. And what you can see is that for most phase 1 studies, you're really not dealing with patients in the 100 in a rare disease population, but here we actually were able to enroll 125 patients to the study, so a really rich data set to look at. And this is sort of what I wanted to show the group here, is that in AML, you have direct access to the compartment of where the disease is, right? It's the bone marrow or in peripheral circulation. So you can readily get almost real-time biopsies in this population, which is really helpful when we're trying to understand the biologic impact and potentially the morphologic changes associated with differentiation. So if there are any hematopathologists in the room, please forgive me because I'm not going to be able to describe these cells perfectly. But if you draw your attention to the left side of the panel, you can see that blasts basically represent the really immature leukemic cells that arise in the bone marrow. In patients who have leukemia, the blast count is just inordinate and basically overruns all the normal cells and the architecture within the bone marrow. On AG120, however, the blast counts start to go down, and what you start to see is the changes in the morphology. So these cells start to differentiate down the myeloid lineage, looking more normal and becoming more polymorphonuclear or neutrophil-like. And this is really important to be able to follow over time in patients because you can see that this is an immediate, almost real-time depiction of how quickly the drug can work in these patients. Unfortunately, in the solid tumor space, we don't have the benefit of being able to get this sort of real-time readout on a cellular level, which is something that I'll speak to in the subsequent slides. We are oftentimes relying solely on imaging. But in this population, what we had was a fair number of patients, I would say the majority of them deriving some clinical benefit, either in the form of complete responses, prolonged stable disease, and partial responses. And this is a swim lane chart. So for those in the room, I think we've gone through several slides in other presentations, so you're probably familiar with what this means. But basically, each bar represents a patient, and their duration on therapy is represented by the x-axis. So you can basically see in months, patients are really coming out several months, 6 months plus, and that's really meaningful in this refractory population where oftentimes patients are progressing within 1 month or even 2 months. What's also noteworthy is in those patients who achieved a complete remission, you were also able to see that some of these patients went on to get bone marrow transplant. So I mentioned earlier that that's really the curative treatment in this patient population, and it's so rare to be able to go on to get a transplant, especially when you have refractory disease. So I think, here in AML, we've really been able to generate very meaningful data, and hopefully we'll be pushing forward quickly into registration-enabling studies. Some of the intriguing data that came out of the data set that were presented at ASH in 2016, so this past December basically, was, well, what other ways can we measure the mutant allele fraction in circulation in these patients and also within the bone marrow beyond what was already being done, and how can we measure this as a response? So it's very early, and I would say that it's probably too soon to know for sure, but at least in a subset of patients, we were able to demonstrate mutational clearance by measuring the variant allele fraction within the tumor cells, the myeloblasts. And the lower limit of detection based on the assay that we were using was 1%. This was considered to be statistically significant. Again, relatively small numbers, but meaningful information and information that will continue to follow throughout the duration of the study. Now I'm going to switch gears and talk about what we're doing in solid tumors. I talked about the 3 tumor types, and what these 3 tumor types have in common beyond the IDH mutation prevalence is the fact that they're very difficult to treat. There are really no standard approved therapies that are efficacious, maybe with the one exception of temozolomide and glioma. And most of these tumor types are really managed by surgery and or relatively ineffective chemotherapy options. So a huge unmet need, and certainly progress needs to be made. The challenges that we face, though, in solid tumors, and I think all of our colleagues in the room can agree to this, independent of whether we're talking about cholangiocarcinoma or potentially other solid tumors, is that we're really driven by these criteria that require radiographic imaging. So you can't always know for sure whether or not a patient is benefiting based on stable disease, for instance, correct? You know, Lippy Gagol earlier today talked about, well, in these postmortem series, you can really see that sometimes CAT scans underestimate the true tumor burden within patients. So it's telling that while radiographic imaging is very important for us and certainly helpful in the clinical setting, it comes with limitations. And unlike the AML space where you can readily biopsy patients and get an answer pretty quickly, it's not as clearly doable operationally in patients with solid tumors. Volumetric imaging, however, is of interest, and it's something that Agios has spent a fair amount of time in trying to understand, specifically in the glioma setting. So typically in conventional imaging, we're really stuck with bidimensional measurements on a static image on a CAT scan and or MRI. With volume, we're really measuring the entire series of that tumor. So if there are finger-like projections, you know, if the tumor's not a complete circumferential mass, it's easier to really get a good feel for whether or not the tumor size is changing over time when you have these irregular borders. There is application to that actually in hepatocellular as well as cholangiocarcinoma. So it's something that we can certainly think about as we talk about imaging in this disease. And then finally, circulating tumor DNA. Many of our colleagues in the room are actively exploring this in their cholangiocarcinoma patients, and it's something certainly that we're collecting in our data set and hopefully we'll be able to report on. Target engagement, well, I talked with you a bit about being able to measure plasma 2Hg, certainly in solid tumors that are systemic, so in cholangiocarcinoma and in chondrosarcoma, less readily doable in glioma patients. And that's why MRS is actually useful in that context. There are a lot of standardization criteria, however, that we're actively employing so that we can better understand this tool and see if it can be used in a clinical context. Finally, mechanism of action, right? So we can show differentiation clearly in AML. Are we showing it in solid tumors? Well, that requires serial biopsies. And as you all know, that's not always readily doable, especially in areas that are difficult to stick a needle in due to the risks, complications, et cetera, et cetera. It may not actually address the clonal heterogeneity that many people have already spoken to. Still doesn't mean that we're not doing it. In fact, I will point out that in our data set in cholangiocarcinoma, we've had several patients very graciously go through paired biopsies on the study, which is really impressive and unanticipated for a phase 1 study where it was actually optional. So I'm very eager and excited to be able to present those data, hopefully at the next meeting. And then finally, why doesn't everybody benefit, right? These are key questions that we're all trying to understand and address, and Agios is actively exploring this in all of our data sets. So just quickly over our glioma patient population. So I'm not going to go into the details and the epidemiology of glioma, but basically it's a progressive disease. The higher grade gliomas are glioblastoma patients, and those are the patients who typically have very progressive, rapidly progressive deterioration, and it's very hard to treat this disease. In the lower grade setting, however, the disease grows more slowly, and sometimes it's even harder to understand the therapeutic impact of a drug because you're not necessarily going to see a lot of tumor shrinkage. You might just see some changes in enhancement characteristics and or growth rates over time. So we've tried to tackle that issue. For starters, we wanted to understand how does our drug behave in both the high-grade and low-grade glioma patients. So non-enhancing is basically patients who don't have contrast-enhancing disease on MRI, and so that basically assumes that they have the lower-grade type of tumor. A lot of the grade is established at time of diagnosis, so years can pass, and most of these tumors over time start to actually transform into high grade. So we use both imaging as well as grading based on diagnosis to get a feel for where the tumor is at any given time point. But what you can see in this data set is that the non-enhancing patient population actually did far better than the enhancing. That's not particularly surprising, but we will be waiting out these data to really be able to benchmark it against some control data to get a feel for what the true activity is here. What's important, as I pointed out, the imaging issue is always a challenge in glioma because it's diffuse in nature, and so it's harder to actually measure adequately. So we've spent a fair amount of time looking at volume change over time, and I think this is just a nice example. We're certainly, how do I go back? This one, okay. We certainly need more work on this, but I think, you know, it points to how can we measure important changes in tumor beyond just the standard criteria we use, like RECIST criteria and or RANO criteria. If you can really look at the pre-treatment slope and then post-treatment slope, you might get a better feel of the kinetics and are we slowing things down meaningfully, and then compare it against other measures such as target engagement and product change over time, which is the RANO criteria. So interesting and exciting. We are actually pursuing a natural history study in IDH mutant glioma patients to be able to use that as our historical comparator. So we're spending a fair amount of time trying to understand this as a potential novel imaging endpoint in this disease. Chondrosarcoma, so what we've presented over the past year at the most recent meeting in Lisbon at the CTOS meeting was looking at plasma circulating 2-HG in patients who had this disease. So it was a sample size of roughly 20 patients. And what we were trying to basically demonstrate is that in this subgroup of patients, can we measure 2-HG? How does it compare to healthy volunteer ranges? And what happens on study? So at this point, we had generated some early data in our phase 1 context, but here we had more sample size to look at. So it was nice to actually be able to show, at least in this patient population, hopefully this will translate to cholangio, that you can measure the oncometabolite, or the biomarker, if you will, in circulation. And just within 1 week or 2 weeks of dosing, we were able to see up to 95% inhibition, so suppression, all the way down to healthy volunteer range, and in some instances even below the healthy volunteer range. So what that tells you is that we're hitting the target, and that's really what we're trying to demonstrate here. What it doesn't tell you is, does that mean that you're actually doing anything for the disease? So that's where you need to really be able to understand the correlation between how this is manifesting, how the tumors look, maybe even under the microscope, and then radiographic imaging, and then following these patients longitudinally. I will point out that at least in 3 of these patients who underwent biopsies, there was similar degree of 2-HG suppression at the tissue level. So again, hopefully maybe what we measure in circulation might adequately mirror what's happening at the level of the tissue. Still a lot more work to be done, and hopefully we'll be able to address that in our cholangiocarcinoma data set. So getting on to cholangiocarcinoma. So again, I think Andrew pointed out earlier that we have completed our dose escalation phase. We've actually completed our expansion phase too. And so I will be focusing solely on the escalation data. And as I mentioned earlier, we'll come back with the expansion data because we certainly have a lot more to talk about. But getting to the favorable safety profile. So one thing that does stand out about AG120, and I think many of you have heard this earlier, is that it's a relatively non-toxic drug. So the grade 3 toxicity rate is about 34%. And so if you were to contrast that against, for instance, gemcitabine cisplatin, it's about 70%. So we're talking about half the toxicity. So in general, very well tolerated. How did these patients do over time? So Andrew commented on the stable disease rate, but it's also important to comment on how durable were these quote-unquote responses and or stable disease. And what you can see in this mostly second-line patient population, second and third-line patient population, a good number of patients, over half of them, were able to stay on study beyond the 4 to 5 month range. And it, based on historical context and historical data on chemotherapy in the second-line setting, you know, that's roughly double the PFS. So it's something that we're paying attention to. We're hoping that with more data, we'll be able to really decipher, you know, why are some patients be able to stay on drug longer, doing well for a longer period of time, versus those patients who progress within the first 2 months of treatment. So these are all very important questions that need to be answered. Again, you know, I spoke briefly about the fact that we've been able to get some tumor biopsies on study. So this is just a representation of 5 of those patients. Very early analyses suggesting that there is reduction in proliferation as marked as demonstrated by Ki67, as well as reduction of 2-HG. So it doesn't necessarily answer whether or not we're causing differentiation, but at least it gives you some insight as to what we're doing with respect to proliferation. Certainly this requires additional work, including RNA sequencing data, morphologic changes, et cetera. So all of this will be part of what we ultimately present. So how did we arrive at this study? Well, many of you in the room know how we arrived at this. You know, we've spent a lot of time thinking about how can we develop AG120 in this disease. We recognize it's a rare tumor in and of itself. And then, of course, with the IDH mutation prevalence being, you know, anywhere from 10 to 25%, it's a rare disease within a rare disease. So operationally, from a drug development standpoint, that's not so easy to tackle when you know, are working on with limited resources, limited time, et cetera. Nonetheless, we all believe that this drug has merit and absolutely should be developed and needs to be studied in an appropriate way so that we can answer very fundamental, important questions. So we had the opportunity to actually present at the first ICRN in last year's ASCO. So that, we had the feedback from the CCF community, but also the greater academic community. And in the meantime, I think we've worked very closely in a very collaborative manner with many of the academicians in the room to really arrive at a trial that we think is the best that we can offer at this point. So I want to thank you all for those efforts. So Andrew touched upon the trial design. This is a global phase 3 study, and I will point out it's Agios' first phase 3 study, so a lot of work has gone into getting this study off the ground. So this went from concept to multiple revisions of protocols to a final protocol in August, to our CTA, which is a clinical trial assay. And so I won't get into the nuances of what that means, but our CTA being approved for use, and then finally having our first 3 sites activated in December. So we moved at lightning speed, literally over a 4-month period. We got from final protocol to 3 sites activated. So that's a testament, I think, to all the work in the room, but also the work internal to Agios and how much we believe in this trial. This study will enroll over basically 186 patients who are IDH1 mutant positive. The study does allow for pre-screening. So what that means is that patients can sign a pre-screening tissue consent at any time point when they're getting, for instance, gemcitabine, cisplatin, et cetera, and determine what their IDH status is. So if you have a patient who has cholangiocarcinoma, you can have them sign the pre-screening consent, which basically just sends the tissue off for testing. Doesn't obligate anyone to do anything else beyond that. So I think that is a very user-friendly aspect of the study and one that you should certainly consider. We will be using next-gen sequencing as part of our trial, and so you can envision multiple other genes and readouts would be part of that panel, and we're more than willing to share those data with our investigators so that they know what might be another option for their patient if, in fact, they are not IDH1 positive. It will be a 2-to-1 randomization. So what that means is that patients have a 2/3 chance of being enrolled to AG120 and a 1/3 chance of being enrolled to a matched placebo. This is a blinded trial, so patients as well as practitioners will not be aware of what the treatment assignment is. The primary endpoint is progression-free survival based on independent review. So what that basically means is that at the site level, your own physician will be making a decision as to whether or not there's evidence of progression, but ultimately how the data get read out will be based on an independent blinded radiology center. So radiologists basically who had no direct contact with the clinicians or the patients. We are allowing crossover at time of progression from the placebo arm to AG120. So this is an important feature of the study and one that we spent a lot of time talking through at the ICRN, as you all may recall. And then important secondary endpoints will include overall survival, overall response rate, safety, and then ultimately quality of life, which we all recognize is critically important to understand as well. So the patient population requires at least 1 prior line of therapy. And if you've had only 1 prior line of therapy, it should have been either a gemcitabine or a 5-FU containing regimen. So basically something that's routinely used in the first line setting. It doesn't require 2 prior lines, just 1. This is a global effort. So as I mentioned already, it's a rare disease, but we also want to gain experience ex-US. We want to understand a little bit more about the epidemiology, which is relatively poorly understood in this tumor type. So we are actively engaging with our European colleagues. Juan Valle has been a tremendous asset and help in getting this off the ground in the EU, and then also with our South Korean colleagues. I talked about patient-reported outcomes and quality of life. So the tools that we'll be using are relatively germane to this patient population and tools that were used in ongoing phase 3 studies, such as the ABC06 study that Juan is running, as well as the primary gemcitabine cisplatin trial that was run in the later 2008-2009 timeframe. So these are basically questions that I think, at least for the most part, will address some of the symptoms assessments that are specific to this tumor type with respect to jaundice, abdominal pain, bloating, fatigue, nausea, and other symptoms including pain, anxiety, et cetera. So I'm not going to go through all the scales, but we feel that these will hopefully adequately capture the patient experience. So in conclusion, Agios is leading the field in cancer metabolism, and we're certainly dedicated to helping unravel some of these key questions around IDH biology, but certainly moving into the metabolic immuno-oncology space, there will be a whole slew of other additional challenges in that realm. I think we've shown proof of concept in hematology for sure with our AML data set. We have a lot more work to do in solid tumors, keeping in mind the challenges that I've outlined. AG120 nonetheless is moving quickly into phase 3 studies, and I think a lot of this is based on the early signs of activity we're seeing and the desire to really study this drug in a meaningful way. We do have both a patient and a provider-facing website that was recently launched this week, so feel free to visit this if you want to get more information about the ongoing trial. So I do want to acknowledge all the team work that went into this. This is a picture of the Agios team at Cape Cod pretending that it's actually summer when it isn't. We're all wearing our coats and it's freezing. But you know, it's an amazing group of individuals. I'm very happy to have joined Agios when I did. Before I'd actually joined my uncle, who's not pictured here, had been diagnosed with intrahepatic cholangiocarcinoma, and he was living in India at the time. And at that time, you know, and some of it's, I think, culturally based as well. He really didn't want to pursue chemotherapy. I think he was concerned about the potential toxicity. And despite me being an oncologist, certainly I'm in, you know, the West and not in India. I was trying to, you know, push him to give it a try, but he ultimately chose not to. He died peacefully. He certainly had the support and love around him. So it is very personal to me. I want you all to know that.